All right. Well, hello, everyone, and welcome to another session of Virtual Spine. I'm absolutely thrilled today to be here with you, and as well as many of our co-hosts, as well as panelists, as we wind down here the last two Thursdays of the academic year. And we will be doing this again starting in July. So as Dr. Dahdaleh says, the show must go on. We're very happy that we're coming close to end of a very successful academic year. So I want to thank everyone for your continued participation, and I hope everyone is enjoying this. A special thanks to a lot of our faculty and panelists as well. With us today is our student fellow, Dr. Kasana, who's been always phenomenal with this. Our faculty, Dr. Gibbs, Dr. Shin, Dr. Than, Dr. Rasuli, Dr. Dahdaleh. Everybody's here today. This is great. As well as some of our panelists like Dr. Galgano, and I think some of our other colleagues will be coming in as well. So great to have everyone here. So today we are going to do what we call the family cases, which are cases and some slides and talks that are internal, if you will. I'm honored to, of course, host my good friend and fellow co-host, Dr. Dahdaleh, who's going to be focusing on the C1, C2 pathology and techniques. But before that, I'm going to start with some technical pearls and complication avoidance in occipital cervical fusions. So we'll cover OC fusions, we'll cover C1, C2 pathologies and techniques, and hopefully this will remain a interactive session for everyone. So Nader, thank you for joining us, and I will try to start and hopefully give you plenty of time to show your excellent cases. All right, so we are going to start. I'm going to just share a couple of a few slides on OC fusions for better or for worse. I ended up doing a lot of these for different reasons, but I'd like to share with everyone my thoughts on some complication avoidance strategies. Everybody says this, right? Everybody reads this: review the anatomy, review the images, which is fine. That's important for all cases. But for me in particular, in this part of the spine, is these two important concepts: knowing what the danger zones are and having a backup plan, right? Everybody says, well, you should have that for all spine cases. I think that is probably more true for the craniovertebral junction than any other part of the spine, because it's a very close area. There's a lot of important real estate there, and you'll come across different things. So you have to have backup plans, especially in terms of fixation techniques. And that's what we're going to discuss. As far as occipital fixation, a lot of the folks here with us are obviously experts, but we also have some trainees and students. So, just a couple of pearls. You obviously want to be below the transverse sinus. And one thing I always do is I always have bone wax ready, nice big ball of bone wax ready, because luckily, we rarely obviously penetrate into where the torcula is or the sinus if you're careful enough, but you may get into a big venous lake or a big bony lake with a lot of venous bleeding, and after you drill, sometimes just a little bit of bone wax will take care of that problem. So as soon as I start drilling my occipital keel entry points, I'm always having bone wax available on the handy in case I see a significant amount of bleeding from there. My strategy for occipital fixation, my go-to, plan A, B, and C is to get a plate, get a nice midline plate. For me, that's worked very nicely in the past. It doesn't matter which system you use. I mean, a lot of systems are excellent. I'm not promoting any one over the other, but achieving 2 or 3 points of fixation in the midline is really good. Most of the time, the screws that I put in are between 8 and 14 millimeters. Occasionally, you can get a little bit, longer than that. I almost always strive to get bicortical, but it's case by case. If I have a younger child and I get a 10 or 12 millimeter screw, I'm happy with that, even if it's not bicortical, right? Whereas on the other hand, if I have an older patient and I probably do want to get bicortical, even if it's 8 or 10 millimeter screws. You have to tap all the way. As we know, the occipital bone is very dense, it's highly cortical, and it's very important that you tap all the way. And for a lot of you that do occipital cervical fusions, you know that if you don't tap all the way, you'll put in the screw, amazing purchase, and then the last two or three millimeters, you can't advance it, and it just spins. And that's because you didn't tap all the way, or worse, you didn't even drill all the way. So that is very, very important. So tapping all the way is key. I tell people this, I say, and I think the only person that corrected me is Dan Shuba, and I'll tell you about that story later. But for me, this is one of the few and only places in the spine. Obviously, we're talking about the occiput, but for us spine surgeons, we call that C0 anyway. That's the only part of the spine where if you get torrential bleeding or if you get CSF back, you can actually put in a pedicle. Excuse me, you can actually put in a screw, right? Because if you get into a venous lake or even worse, you can put in the screw. That's not going to be an issue. And if you get CSF back, let's say there's adherence of dura in an elderly patient, or you inadvertently penetrate the dura in the posterior fossa, I wouldn't put flow seal in there. You can put bone wax and go to try a different trajectory or a different entry point, but I have no problem putting in a short screw in the base of the occiput if I see CSF or blood back. And that's one of the few places where you can do that. And of course, the last thing I have here at the bottom is have a backup plan, right? In my previous practice, I used to help a colleague who did a lot of Chiari instability surgery, and we'll leave that for another day about what that means. But I ended up performing a lot of OC fusions for craniocervical instability and Chiaris. And sometimes you have, young or old patients without, with a Chiari decompression. You can do the condyle screws, right, that a few people talk about, but having done a few of them, I can tell you they're absolutely not fun at all. And I rather utilize the occipital bone, whether if I can get a midline plate even high, that's fine. If not, you can go laterally. Obviously, laterally, you're not going to be able to put in long screws, but you can utilize Songer cables, you can utilize different types of fixation points. The point is, be versatile and have a lot of tools in your toolbox at the OC junction, because you never know what you're going to need that day. So be adept with wires, cables, as well as your traditional screws. Dr. Dahdaleh is going to go over the C1, C2 anatomy, but those of you who know me know that this is one of my favorite slides. I always put this up on Twitter, which is this is for me the most important cut on the CAT scan when I'm doing a complex OC surgery. If I'm putting a C2 screw, I want to see where that vertebral artery is. Is it a high riding one? And if it's high riding, I'm putting in a pars. If it's not a high riding one, I can put either a long pars screw or a pedicle screw. So for me, this is absolutely the most important cut on the imaging. This is I'm shamelessly kind of promoting one of my cadaveric studies back in the day. But there's a difference between a pars and a pedicle screw. We use it interchangeably. Some people call it, what is it, parsicle or I don't know. John Rasuli, I don't know what you call it. I've heard you call that a few times.
It's parsicle. They wrote a paper at Thomas Jefferson describing it.
There you go, a parsicle screw.
Parsicle, yeah.
You can call it whatever you want, but I'll tell you what you can't do. And I see this a lot, unfortunately. You can't say, well, I'm just going to put a pedicle screw if you don't confirm that the patient has a decent sized pedicle. And vice versa. You can't just say, well, I'm just going to put a pars screw because I can't get a pedicle screw without knowing whether a patient can tolerate it or not. Where people get in trouble is they put a pedicle screw in a patient with a high riding vert or no pedicle. That's where you get in trouble. So you can put a pars, you can put a pedicle screw, but you have to know the difference and when you can use either. Again, I'm going to skip this because Dr. Dahdaleh is going to talk about this, but obviously it's very important real estate at C1 and C2. I've said this before, C2 is king. So many things you can do with C2, pars screw, pedicle screw, cables, translaminar screw. And this is, I think, really the only time I've had to do this, but I put a pars, pedicle, and translaminar screw in one at the same level for fixation. Back to this slide, which just demonstrates the importance of having multiple, skill sets at the OC junction. I don't use structural allograft all the time. I know, kind of the purists among us will get upset, but I have had really good luck without needing to use structural allograft all the time. But sometimes I will. If there's a huge gap, I will use structural allograft and I'll cable it into the rods. So just have a diverse set of skill sets for that. I'm going to skip this for a little bit, but then this is what I'm going to spend the last 5 minutes on before I relinquish to Dr. Dahdaleh. Let's see, John, what's wrong with this lateral X-ray? John Rassouli. What do you think, Dr. Rassouli?
If you just look at the kind of the Frankfurt line on this patient, the patient's horizontal gaze is a little bit downward pointing there.
Yeah, exactly. So, you know, when I look at this, and, you know, a lot of us have learned this the hard way. Nader, I'm sorry, go ahead.
I was going to say, if you measure out his CBVA, it's probably pretty negative. It is he's a bit of a kyphotic or flexed gaze.
Exactly, kyphosed or flexed. So this is somebody that was fused like this, and on the lateral X-ray, you see the mandible, you see the angle of the mandible. It's basically touching the vertebral bodies. If that angle of the mandible is touching the vertebral bodies, for me, that's not a great way to fixate that patient, because they're likely tucked in and they're likely going to have swallowing issues and potentially breathing issues. And this patient actually ended up getting revised. It can happen to anyone. It wasn't my case, but it definitely can happen. So I learned from this case is, you know, to make sure that you leave some space behind the mandible on X-ray. That's just one way of seeing it. But that's right. That's the problem. Is for me, alignment is very critical in OC fusions. You know, I guess we used to call it, you know, reader's gaze, but now I call it text gaze because everybody's texting. So you don't want to fuse patient in text gaze or bird watcher's gaze. Not looking up, not looking down. You want to be as neutral and horizontal as possible. So actually, this is that patient. This is that patient that had that was very tucked in. You could see what, you know, a couple things that I look at is I look at the chin. And I'm telling you, even in very big people, you should still be able to get that chin fold out. You should see you shouldn't see any folds there. And when you don't see any folds there, that means they're not tucked in. So this was revised, and this is how she looked after the revision with the removal of the, with kind of taking care of that tucked in posture. And this is her post-op. I want to show this video, and I've shared this with a few colleagues in the past. This is how kind of I now do these. Is I do like the Mayfield pins. If we need to do a decompression, I'm happy to flex them. But just by simply turning the knob of the Mayfield, I just extend them back into the position I want. So I don't readjust everything. I literally fix them in place, and then just with that with the Mayfield knob, I'm able to flex them to the desired position and extend them. And you see the difference here. This is flexed. You see the fold here. This is nicely extended, and this is the position I like to fuse patients in, on the right side, not on the left. So I just wanted to share with everybody a few pearls and kind of techniques that have evolved over the past few years in my own practice and how I look at the OC junction. But again, the big plans are, or the big points are, make sure you have a backup plan. Make sure you know the detailed anatomy, especially in a complex case. And number three, look at different parameters in the OR to make sure you're not flexing in fusion, you're not fusing in flexion, which is more of a problem than fusing in extension. When you fuse somebody in extension, they can usually accommodate for that with their subaxial spine. It hurts, but they can accommodate for it. If you fuse them in flexion, they can't accommodate for that. They can't extend their subaxial spine enough. So I just wanted to share that. Otherwise, we will go to Dr. Dahdaleh to show us some excellent cases and talk more about the C1, C2 junction. Thanks, Nader, for letting me jump into your session and discussing these.
Sounds good. Thank you so much, Ali. Beautiful. I mean, actually, these pearls should be always included with any CVJ talk. I mean, these are really important decision-making, you know, making sure that you keep the occipital cervical alignment neutral, you know, not extended, not flexed. If you're flexed, you can't breathe, you can't swallow. You're extended, you can't look down. But definitely an extension is less, you can adjust to it. And flexion, you can adjust to that. So I totally agree with what Dr. Baaj alluded to. Quickly here, you know, this, I put these slides together actually this morning, geared towards fellows and residents more than faculty or experienced surgeons. So, basically, what's the upper cervical spine, or the CVJ, or the CCJ, craniocervical junctions? Basically, we're talking about two joints, the condylar C1 joint and the atlantoaxial joint, OC1 joint and C1-C2 joint. It's definitely most complex anatomically and biomechanically. That's how C1 looks like, and that's how C2 looks like. We're not going to go into the details, but we need to remember that there's a synovial joint here, and anterior to the dens, articulating with the C2 posterior C1 posterior arch. And if this joint gets inflamed, it can invite into ligamentous laxity, and then C1, C2 subluxation, then pannus formation, and sometimes cranial settling. C1, the OC1 joint is cup-like in the coronal sagittal plane, allowing flexion and extension, while the C1, C2 joint is convex in orientation, allowing axial rotation about the axis, limited by the transverse atlateal ligament posteriorly. While the joint orientation determines the direction of motion, the stabilizers of the upper cervical spine, or the CVJ, are the ligaments. And we need to remember three ligaments, the major ligaments that account for spinal stability in the upper cervical spine. Firstly is the alar ligaments that span the tip of the dens to the condyles laterally, and then the transverse atlantal ligaments, which span the lateral masses of C1. And then the third most important and ligaments that stabilize the CVJ are the capsular ligaments at the level of the C1, C2, and the occiput C1 joints. A lot of motion occurs at the CVJ. More than 50% of neck motion occurs at the CVJ. Occiput C1 mainly flexion and extension. A little lateral bending, axial rotation because of the alar ligaments. These limit axial rotation and lateral bending. C1, C2, there's a lot of axial rotation, but there's also substantial flexion extension. And we need to remember that the alar ligaments stabilize the CVJ in axial rotation. So they act as a check. They keep the CVJ in check in terms of lateral bending and axial rotation. So the left-sided alar ligament limits right-sided axial rotation and right lateral bending, and vice versa. One more thing we need to remember, that most of the cervical lordosis in the cervical spine is derived from the CVJ, or the upper cervical spine. So the 40% average lordosis in the CVJ of the cervical spine, most of it comes from mainly C1, C2. So that's why you always want to, even if you're not including the occiput, you want to maintain that angle, C1, C2 angle. No one talks about that too much, but that really contributes a lot to the cervical lordosis. So, sometimes we flex the patient to get into the C1, C2 joint, even without going to the occiput. We need to make sure that we keep that angle anatomically appropriately lordotic. Why is it challenging to achieve a fusion at the CVJ? Three major challenges. First of all, there's a lot of forces to combat, a lot of motion you need to eliminate to achieve a fusion. Number two is the bone density. You have the corticocancellous bone density of the occiput. It's much different than the corticocancellous bone density in the C1 and C2, the upper cervical spine. So that makes it challenging for a fusion to take. And the last thing is the gap. There's a lot of gap to fill. And maybe we'll add a fourth one. When you put a lot of hardware, there's not too much space to put bone graft. So that's why sometimes we resort to accessing the atlantoaxial joint to use it as a fusion surface. When we expose the CVJ, it's really important to pay attention to the bony, ligamentous, and also vascular anatomy. You can get a vascular injury without even putting a screw in yet. So you open the skin, you get down, you maintain your fascial planes and respect the fascial planes, get down to the nuchal ligament, and stay in the midline, and then you do subperiosteal dissection. Firstly, you expose the occiput and C2. C1 is a little bit deeper. Then you get to the posterior arch of C1. Don't use the bovie more than 1 centimeter on both sides, because you may run into the vertebral artery. So once you get there, you start using a freer or number using a freer or number 1 Penfield subperiosteally. Stay caudal. You have no business being above. Stay caudal, and then you get down to the lateral masses. And the way you know where the lateral masses are located is by exposing C2. So you can see the lateral aspect of the lateral mass, and that would direct you to where the lateral mass of C1, where to dip when you're dissecting down the posterior arch of C1. Because sometimes you keep going laterally and you don't want to dip there at the level of the foramina transversarium, at the level of the transverse process of C1. I've seen that happen. You know, they keep going. People who don't expose C2 adequately, they keep going with the posterior arch of C1, and you don't really know how wide it is. So you always derive the limits of the medial and the lateral aspect of the lateral masses are derived from the more superficial limits of the C1 lateral masses, if you will. Now let's start with some cases. You know, we can engage now the participants because we're a case-based conference. This is a 60-year-old woman, and this is a case that usually is presented in oral boards with rheumatoid arthritis, so presented with a 6-month history of neck pain, mainly upper neck pain with neck movements, neurologically normal. And that's her x-ray. So what do you see here? Who's with us here? Panelists or everyone's... Michael is on the way to the operating room, but we'll ask him before he leaves. What do you see, Dr. Galgano, since you have your camera on?
Give me a second. I've got you guys on my phone. I've got to zoom up on here. So it looks like
just so I have to say this because this is being recorded. Okay, I have to say this. Dr. Galgano is a very good surgeon. He is not operating. He is on his way to surgery, but he's not operating.
He's not operating. Yeah.
He's not operating and joining us, from the OR because, there was. Did you guys hear the story about this guy in California who joined his court hearing from as he was operating? Okay, we're not doing that here. I just want to make sure everybody's aware of that. Patient safety comes first.
Yeah, 100%. Yeah.
Yeah, I'm definitely not operating at the moment. So it looks like that let's see, the interval between the front of the dens and C1 looks like there's an increased gap on dynamic imaging. So that's kind of the first thing that pops out at me. Looks like that there's some C1, C2 instability.
Exactly, and that's pretty common in patients with rheumatoid arthritis. Like we got a lot of patients, and sometimes incidentally found to have atlantoaxial instability, but they're asymptomatic. Pretty prevalent in patients with rheumatoid arthritis. Some reports up to 15%, 20%. So this patient's symptomatic. When she moves her neck, she has significant pain. It's been going on for a few months. So what do you suggest? How do you want to manage this patient? Let's see who's with us. Jonathan, what do you think? This patient comes to your clinic.
I get at least get another form of imaging, like an MRI or a CAT scan, just to kind of look at her anatomy.
So this is the MR.
She does not have oftentimes these patients have a pretty significant degenerative odontoid pannus. And if that's the case, then I always question whether or not you need to decompress those patients as well too, because sometimes I know just instrumenting and fusing them alone can reduce the size of that pannus. This is not the case for her, obviously, but okay. I mean, I say the MRI looks pretty benign, pretty bland, not really very remarkable. I'm assuming there's some sort of catch here, or is it?
No, the MR is normal. The MR looks okay. There's no pannus. There's no compression.
Okay.
Just neck pain due to atlantoaxial instability for 6 months.
So I would say this is pretty, without actually looking at the measurements, but this is pretty bread and butter, patient with rheumatoid arthritis, with atlantoaxial instability, and no presence of odontoid pannus. I would err towards, and she has neck pain, obviously, with movement. I would err towards doing a C1-2 fusion on her.
That sounds good. When
Nader,
I saw her. Mm-hmm.
Oh, Nader, can I ask a question real quick? Actually, I have 3 questions.
Sure.
Sorry, but they'll answer. That's also going to address something that Ollie just put in the chat box. So before you go on to treatment, it's about the imaging. So my first question is, how old is this case? Is this recent?
No, this is
old?
one of my first C1, C2s at Northwestern. Like
Okay.
this is like she's
Well, I asked because
highly
when I was
functional
doing research
lady.
on,
Yeah.
Mhm.
So she's yeah, I think 2013, approximately 14. So about 9 years.
So I asked because when I did research on this for a talk I was giving, I read that actually cervical spine rheumatoid is less common now because they're treated earlier and more effectively. That was number one. My second question is about what Ali said in the chat box and what JR just said as well. Beautiful MRI. How often is that you have instability like that with no other radiologic findings of rheumatoid, no erosions, no advanced degenerative changes? That's question number two.
That's kind of what I was expecting too. Yeah.
Yeah, that's what you were saying. And then number three, before you answer that, is the other question is who would fuse and who would watch and keep in a collar. That's from Ollie also. How quickly do those medications work if you do not fuse? So that might be down the road a little bit. So those are all my questions that I had to ask before I forgot.
Wendy, these are fantastic questions and they're all legitimate. Absolutely. So for this, for instance, like you see this patient, as you mentioned, her MR is really, I mean, you know, minimal degenerative disc disease, and there's no other evidence of a rheumatoid spine, you know, there's no spondylolisthesis, there's no pannus, you know, the ADI, you know, here you can see it increases in flexion extension, but there's no spinal cord compression. So the first thing that I did personally, I said, okay, let's put you on a neck collar for comfort, and let's speak with your rheumatologist, make sure that your medications are optimized. Make sure if there's, you know, because sometimes these patients may not be compliant. Sometimes they have osteoporosis that need to be optimized. And I mean, these are the things you want to think about, especially in the absence of a neurological deficit or significant instability. So we tried a collar for 3 months. She was definitely optimized. Her medication was optimized, and she started being on narcotics. And she's a highly functional lady. And then she was sent back to me to clinic with worsening symptoms, no changes in radiographs, like the similar subluxation, no major changes. And at that point, what do you want to do? I mean, you know, we tried non-surgical treatment. We optimized her medications, whatever they may be, and she's still symptomatic.
Question: what is there a role for? Why would you keep her in a? I'm just purely asking. What would be the end game there with a rigid collar? It's just whatever the rest of her life.
Just for comfort. No, great question. Just for comfort while her rheumatoid medications are being optimized. That's it. Just a trial.
Okay.
You know, I mean, just for comfort. There's no end result. We're not going to expect. You know, she gets better, great. We remove the neck collar. She doesn't get better, then we need to do something else. What would you do? As you mentioned, Jonathan, we proceeded with the C1, C2 fusion.
Nader, can I ask you something before you talk about the fusion?
Yeah.
Again, this is getting a little bit off topic, but I think this is such an important point about C1, C2. So I'm going to give you 3 scenarios, and I don't know the answer to this. I'd love for, you know, Jonathan, Wendy, Mike, and others to kind of address this, but I'm going to give you 3 scenarios, right? So this patient with rheumatoid arthritis, elderly patient, rheumatoid arthritis, dynamic instability, neck pain, right? Probably want to intervene or, you know, fuse her. The other common scenario that for some reason I see a lot is, say, the younger patient in their 20s or 30s who either have an incidental finding of dynamic C1, C2 instability, or they were playing sports or something, and then they have C1, C2 ligamentous instability with, say, 2 to 3 millimeter of subluxations on flexion extensions. And let's say all of them have unremarkable MRIs in terms of cord compression, right? This is either ligamentous laxity that is chronic or acute. Is your paradigm, and this is a loaded question, but is your paradigm different for all these 3 patients? Do you think all of these 3 patients need a C1, C2 fusion? Sometimes I struggle with the younger patient that this was incidentally found. And you get the flexion extensions and there's dynamic instability. Can you just, you, JR, and others, Wendy, just comment on that?
Yes, so Ali, why would you have got, I mean, I don't understand why you would get a FlexDex on a young person unless there was reason. They had, you were suspicious already for some reason.
I agree with you 100%. Wendy, sometimes you have a patient who has like incidental head trauma for some reason, and they get a CT head and cervical spine. And then you see they have absolutely no neck pain whatsoever, completely asymptomatic. It was just gotten as part of the trauma workup. And then they have like some random increase in their ADI. It's like 4 millimeters for some reason, right? So you don't kind of know what to do with that. And let's say, okay, so you just watch them, see how they do. You see them in your clinic like a month later, and you get some x-rays or you get another CAT scan, whatever you want to do. It's still increased, right? So and then the patient's completely asymptomatic. They have no pain whatsoever, no myelopathic symptoms. What do you do with that patient? I struggle with this myself too. I let what I do is I've had a couple of these patients. I just counsel them. I show them the finding. I show them the imaging. I tell them what's going on. We don't really know if this happened from the trauma. Most likely it's something congenital or incidental. But I really let their pain dictate whether or not it's quote unquote unstable. If they're not having any pain, I think it's reasonable to watch them. If they're having pain and having some sort of symptoms, even if it's like the vaguest little thing, I personally would be a bit aggressive on those patients because the morbidity of a C1-2 fusion, especially in those patients, is very low. They tend to do very, very well.
And
back to the question of rheumatoid arthritis for a second. So the DMARDs actually will keep it from progressing if they that was what this original case was rheumatoid. But I don't think it would ever stop the instability. You're not going to repair the ligament. Is that true? So that kind of affects what you're going to do as well, right?
That's correct. I mean, it goes down to symptomatology. You know, I mean, if let's say the DMARDs stop the progression and her pain has improved. I mean, this lady was like on oral like narcotics, and she's a highly functional individual. So incidental findings like this, sometimes they do flexion extension for so many different reasons. And for instance, the patients with Down syndrome, right? Like they always even screen before an operation, and they find C1-C2 instability. What should we do with that? Certainly, we're not gonna fuse them, right? Like if they're asymptomatic, but certainly we'll tell them with the intubation, you need to use caution, no hyperextension. If there's an opportunity for a sleeve fiber optic intubation, better. All these things. But someone who has incidentally found increased ADI and flexion extension with no symptoms, I'll certainly have them come back for a couple of follow-ups, but I would not operate on a patient who's asymptomatic. I mean, we follow patients with myelopathy, not myelopathy, like severe stenosis who are asymptomatic or early myelopathy. We're comfortable following them. And that pathology is definitely more serious than just mild subluxation in an asymptomatic individual. The question is, how long do you follow them?
Sorry, Nader. So this particular case, and this patient, let's say you put her in a collar. Let's say she comes back to you after 3 months and say, "Wow, Dr. Dahdaleh, my pain is a lot better. I don't have any more pain." Then you get a flexion extension, and she still has that listhesis. What would you do in that patient?
I tell her, if you have no pain, come back, see me in 6 months, and we'll see if the listhesis is getting worse, and see if the DMARDs are taking effect. But if the patient improved with conservative treatment, then that's a success. That we don't proceed with surgical intervention. That's why we intervene with non-surgical intervention first to see if that works. If it works, then fantastic. Then we don't proceed with surgery, obviously. But the question is, how do you follow them? And that's it's different for different. It's more art than a science. But I would definitely follow them and then space the follow-up. I mean. Instead of 6 months, then 1 year, then every 3 years. But I personally like to follow them. If they were symptomatic, then they improved. But this lady definitely did not improve, and you got a call from the rheumatologist, and things are getting worse. So we'll pull the trigger. What's your goal? What would you do if you want to stabilize this patient? JR.
I would do a C1-2 lateral mass screws and pars or parsable screws, Harms construct. Okay, and that's what we did. And 3 months later, her pain was about 1, and a year later, it was she had no pain. She had osteoporosis, obviously, and this was also she was on medications for that. So how do you put a C1 screw? As we mentioned, the options for a C1 screw is mainly a lateral mass screw. Subperiosteal dissection at the inferior edge of the posterior arch of C1. We have no business being here, close to the vert and the groove. Continue, and then
and then you dip into the lateral mass of C1. Now, definitely you want to expose C2 first and see the lateral border of the lateral mass of C2. Let's call this a lateral mass or the facet of C2. And this would determine approximately where the lateral border of the lateral mass of C1 is. So because sometimes if you're not exposed to C2, you continue dissecting lateral and you want to dip here, you don't want to do that. So you always want to orient yourself and estimate where the lateral mass screw is, and you get down, and then you're dissecting. There's the venous plexus. You want to preemptively buzz it and be patient, and you're pushing down the C1 nerve root to create space to get to the entry point. Usually the entry point is in the middle of the lateral mass at a level of an unnamed emissary vein. There's sometimes an emissary vein there that would help you with the entry point, but usually that's the entry point is pretty standard, middle of the lateral mass, or a touch lateral to the midpoint. And sometimes you drill a small trough in the posterior arch of C1 to improve the exposure of the lateral mass, especially if you don't want to sack the C2 nerve root. And then you angle about 10 degrees medially, and then if you want to use a lateral X-ray, you aim towards the tubercle, but don't go. You got to put the screw short of the tubercle. Usually these are lax screws or fully threaded screws that up to 34 millimeters in length. Now, danger zones here. You don't want to put too long of a screw because you can hit the carotid artery anteriorly. If you're a bit too lateral, what is this? That's the hypoglossal nerve. Too long of a screw and too medial, that's the oropharynx. Too lateral, that's the vert. Too medial, that's the spinal cord. So you always want to make sure there are danger zones in that area, and you want to make sure that you're oriented towards that. You can get a carotid artery injury actually by putting too long of a screw bicortical. Initially, when I started doing them, I used to do bicortical and then get a post-op CT. It's like, oof, man, that's too close. Because look, with the lateral X-ray, the tip of the tubercle, see, it's so far anterior than it can fool you. So really don't get that screw long toward at the level of the tubercle. You want to keep it short. You want to make sure where the lateral mass is. And you can see that on an X-ray too, on a lateral X-ray. And now I freehand them these days, but when I use X-rays, I use a lateral view. And for the pars screw, entry point is in the middle of the pars. So you identify the medial aspect of the facet, lateral aspect. It's usually in the mid portion between the superior articular process and inferior articular process. And then you gotta go about 20 degrees medially and then maybe 20 degrees cranially along the pars. And you want to make sure that it's not a high riding, there's no high riding vert over there. I'll explain later if I have time how to put a pedicle screw too, and the entry point is right here. So the inflection point of the pars, it's at the lateral aspect of the facet, if you will, and it's a very different entry point, and that's the pedicle screw. More lateral and superior than an entry point for the pars. Very different. So translaminar screw is an option, obviously, and I'm not going to go into the details of that too. You can do it if you want to do a laminectomy. So I'm going to show it.
Do you always preserve the C2 ganglion, or do you ever take it? Because actually, there's a very nice paper that Ali wrote, looking at the anatomy of the C2 ganglion and whether or not it affects patient outcomes by sacrificing it. I think the conclusion in your paper, Ali, was that it didn't really affect patient outcomes very much, if I'm not mistaken. But I'm just curious what your protocol is. Do you always preserve it, or do you
almost always I preserve it, even if I want to get into the joint. If you flex the neck a little bit, you can get into the joint inferiorly and can preserve it if you want to. So the reason you want to sacrifice it improves the exposure, and then you can get into the joint and you can arthrodese it by either placing bone graft or a small sponge of BMP. But I usually, like, let's say 90% of the time I'll preserve it. If it's really too tight and there's not much space, you'll sack it. But I'll make an effort to preserve it by flexing the neck a little bit, if it's not an OC fusion. So here's a series of C2 fractures, each treated differently. I'm going to go through them relatively fast because it just shows the different options you have to treating these patients with a C2 fracture. So this is a 64-year-old woman, and she has osteoporosis. She was on treatment. She fell, had a hyperextension injury. She was braced for 6 months before I saw her. She had upper neck pain upon movement. So she, when she moves her neck, even within the brace, she would have pain. But the brace definitely helps her neck pain. So that's her injury. That's the scan at the index injury. So what do you see here quickly, Wendy?
I'm going to ask you while I'm looking at this, 6 months of a brace, is that soft or hard collar?
That hard collar, Aspen. She was in an Aspen. Yep.
Is that not bad for patients that like rubs under their chin and stuff? Is that not hard to live with, especially for 6 months, or is that standard?
She was doing okay. Usually I brace for shorter periods. I've certainly braced for 6 months myself too. I mean,
Wow.
but then I saw her. She was 6 months into using a hard collar.
So you asked what's here. So you do still have displacement of the superior fragment of the tip of the odontoid. It doesn't. It's pretty small, but it doesn't look like it's healing at all. You don't have any.
No. So that's the fracture day one. That's the fracture when she fell down.
Oh, that's day one. So you're comparing it to an X-ray then?
Yeah, this is the X-ray standing. That's his X-ray that she's standing, and that's the supine.
Your alignment, I guess, looks better, but you can't really tell in the margins. It's not the same. You're not looking at the same thing, but maybe better alignment. I'm not sure.
Yeah, I agree. I mean, it's hard to compare a CT to an X-ray, but the alignment with the upright film looks acceptable. Would you treat it differently, Ali? I mean, she came in with this fracture, intact neurologically, and she was given an Aspen collar, mobilized with a brace, and her pain was okay.
Yes. Sorry, Nader, I missed the initial point. So, but this is her initial CT right there?
Yes.
Yeah, I don't know if I would treat that with a call. I don't know if I would treat that conservatively, to be honest with you. How old is she again? Or
64. 64.
Yeah, I mean, if I don't know if I think there is I think there's a certain degree of subluxation there, and this is one that I would probably intervene surgically, and I'm very conservative with C2 fractures, very conservative. This one probably I would lean towards operating.
Okay, so she was braced for 3 months, and that's her scan. And then they told, okay, it's not healing. Well, it's looking worse. Obviously, the gap is more, but when she stands up, there's no subluxation. So they continued with the brace for another 3 months. So she saw me at the 6 months, and that's her 6 month, not 3 months. That's a 6 months after her injury when she saw me, and she was at that time counseled to have an operation. So she came in a second opinion. So certainly the fracture is not healing, and she's symptomatic. She has neck pain. She does. It's not like she's asymptomatic. She has neck pain. So certainly this case, pseudoarthrosis, non-union, 6 months of bracing, symptomatic with neck pain. With, I did a flex X actually to see, and didn't move much, but still she's symptomatic. Isn't that interesting? Didn't move much, but she's symptomatic. We ended up doing a C1, C2. MR is benign. So that's C1, C2.
Nader, can you go back one for a second to your flex X? Tell me this also. These are random questions, but maybe I think of them. Look how far back she's extending her neck.
Yeah.
People in a lot of pain usually do that. Do you think how symptomatic was she?
She's symptomatic.
When I see people and they're not moving their neck much on those, I know they're in pain.
Super smart, but that is 6 months after the injury. I mean, she's not like she's protecting because of pain. That's like 6 months after the injury, and she's definitely not comfortable and symptomatic from pain. But certainly she made an effort with this flexion extension X-ray, so she will be able to flex and extend well. Yeah, I get what you're saying. In the acute phase, they're guarding, but this is 6 months into the fracture, and she uses the brace, and still symptomatic. So ended up doing a C1, C2 fusion, use a rib graft, and that's a year later, and she's asymptomatic. Now, before I didn't used to use a transverse corrector. Now I use almost universal transverse connector, really important. Initially, when I used to do C1, C2s, when I see them in follow-up, the screws will look like this. The C1 rotates a little bit and goes like this, like the rods will angle this way. So by putting a cross connector, that helped resist rotation. Here's another person, 54, bicycle accident, braced for 4 months, neck pain upon movement, neurologically normal. That's his index fracture, C2. Mobilized with a neck collar. And that's the fracture 3 months later. Has neck pain. What would you do to this patient?
So 3 months later, Nader, this is somebody that at 3 months, I would get dynamic films. And if he's not moving or just moving a millimeter or two, I have no problem keeping him in a collar for, say, another 6 to 12 weeks. If he has significant movement on flexion extension at 3 months with this CAT scan, then I would probably offer surgery. I think the alignment still looks good to me. There's probably early kind of bone bridging. So this can go both ways depending on the dynamic films.
Okay.
Hey, Nader, do you have an MRI of this one? Because this prevertebral soft tissues on that last, look at this. That's on the next one, on your last one. The prevertebral soft tissues in front of C1 and C2, that's way too much. And so I'm wondering, does he have like still some inflammation or something going on there? Or you don't have an MRI of that, do you? It's just, you see how thick that is. That's kind of weird.
Is it too thick? Yeah, I mean, it may be.
That's that's too thick, and that's weird that after it's been healing that long, it would be worse than it was before.
Right. Yeah, I agree. I mean, so I agree with Ellie, and I agree with you. I'm not sure why he has prevertebral soft tissue swelling 3 months out, even 4 months out. But he's symptomatic when he moves his neck. He's a bit anxious. I did not do Flex X on this person, and we offered him at that stage, continue bracing versus doing a C1, C2 fusion. And he opted for C1, C2 fusion. I mean, alignment is okay, and we did that. He had a high riding vert. You can see that here. And see, ultimately the fracture healed. And I used rib graft with the initial case that I did, I used to use rib graft. Now I use BMP and get in the joint. So here's another case. Car accident, not care accident, car accident, C2 fracture, braced for 4 months, came to establish care in an Aspen collar, neurologically normal, no neck pain. And that's his index fracture. Brace for 4 months. That's how it looks like when he stood up. That's when he was mobilized right away. That's his day 1 after the injury with a neck brace. No neck pain.
Yeah, he has a little bit of listhesis there, Wendy, don't you think? If it's between C1 and C2, he's probably got a few millimeters.
On this, actually, I can't tell. It looks like it. Yeah, it's too small for me though.
Yeah,
I agree.
Maybe there's like a little bit of.
Wait, are you saying there's no pre-dental widening? Is that what you're saying? That just the fracture fragments, right?
Yeah, I'm looking at the posterior spinal laminar line, and I see it all of a sudden. Can you go back to the previous picture? Well, I guess it's hard to compare here. I'm just wondering if that C1 ring is now a few millimeters, has translated ventrally. But I may be wrong. That's tough to tell.
No, I think that's okay. I think it looks the same, just a different, the head is in a different position because it's an X-ray versus CT when they're laying down. And this is probably standing, right, Nader?
Yes, that's standing, upright X-ray, yep, with an Aspen collar. So this is when he saw me, obviously, and you can see there's some healing already taking place, right? So what would you do with this patient? I continued bracing for a few more months, 3 more months, and that says follow-up, no pain, he never had pain, and total healing of the fracture. So this fracture is a C2 fracture that healed with bracing, okay? And the good news is he never had symptoms, so we had liberty of continuing bracing and watching him. This is another case, 71, recent history of stroke on aspirin, anticoagulation, AFib, osteoporosis, unwitnessed fall, had a C2 fracture, presented 3 months later with a brace. And that's her X-ray. You can't see much there because of the osteoporosis, but that's her CT. That's the CT at the index. So I'm showing the CTs at the index injury before the 3 months bracing. And then that's the X-ray upright, and that's the actually, sorry. So yeah, this is
Nader, go back for a second. You said unwitnessed fall. This doesn't look like an acute fracture right here, actually.
yeah,
On the
unwitnessed.
CT, that's not acute. That's
Yeah,
so
this is a 3 month. Yeah, that's when I saw her. So that's when I saw her 3 months later. Yep. Multiple medical problems, hemiparetic because of the stroke, no neck pain, osteoporosis.
Dynamic X-rays, yes or no?
Not yet. I just, yeah, not yet. So I continued bracing her. You know, I said, well, you know, you're high risk, have osteoporosis, you're on like multiple anticoagulants. The fracture doesn't look healed, obviously, 3 months later, but continued watching her. The alignment looked okay. Here's a year later. And you can see he still has non-union, maybe the anterior arch of C1 fused to the fragment. Put her in a soft collar. She never had symptoms. Then I flexed exter a year later, and she did not move. So stable union, or like a fibrous union. I counted that as a fibrous union, and that's about it. That's the end of the story with her. How, you know, I mean, these are the patients with a C2 fracture, each managed differently, tailored upon their bone density, tailored upon their, you know, stability and medical problems. You know, it's not like a one treatment algorithm. You got to be versatile and take into account multiple things. So that's why C2 fractures are fascinating, and I really follow them in my clinic to learn. Now, what I learned, the patients that I treat conservatively, I follow them much longer than the ones that I treat surgically. Ones that I treat surgically, 3 more follow-ups, a year out, and that's it. They're PRN. But the patients who have, you know, a stable union or like a non-union without even being stable with multiple medical problems, I keep watching them, making sure that they're not subluxing. So that's also one advantage of surgery if it's appropriate. Here's a case of a patient with Ehlers-Danlos syndrome, 25 years old. She presented with neck pain and headaches, gait ataxia, pre-syncope when she flexes her neck downwards. So chronic symptoms. Finished college with that and debilitating symptoms and seen multiple opinions. On exam, the findings are brisk reflexes in the uppers and lowers, decreased gag and cuff reflexes, and she also had a positive Hoffman's bilaterally. And that's her MRI and the CAT scan. What do you guys see?
So would you consider this a case of basilar imagination or basilar depression? Because if you draw a line at her hard palate, right? I know it's cut off in a CAT scan, but I bet the odontoid is pretty significantly above that, right?
I mean, if McRae's line, I like McRae's line, so it's not beyond McRae's line from the basement to the epistheon, but certainly the clival canal angle is acute. You know, that's not normal. It's 130. It should be at least more than 145. So there is some kinking here. I agree with that, but certainly not a straightforward case.
Right.
And flexion extension X-rays, maybe mild, a touch of a millimeter subluxation, not something that stands out, okay? But she had certainly symptoms and she has objective findings, you know, ligamentous laxity. So flexion extension MR, you can see here, there's a little bit of stretching of the cervical medullary junction, inflection, and it's better than extension. Now, you know, you got to counsel these patients a lot, and she's seen multiple opinions from non-surgical treatment to OC fusions. And after extensive counseling, we'd say, okay, well, she has some sort of a C1, C2 instability causing these brainstem related symptoms. Now, one thing you can see here, there's an early syrinx here or a dilated canal. So that can be due to also intermittent impairment of CSF flow. But certainly this is not something that you make a decision right away and it's slam dunk. Extensive counseling and you know, we saw her multiple times, and then we proceeded with a C1 C3 fusion with a crosslink. And this is the pedicle screw of C2, a pretty long, excellent screw. And the best paper to learn how to place it freehand is by Shuba and Wolinski. And that's the entry point for the pedicle screw. It's pretty high up. So you got to dissect C2 fully, including the joint. And then you need to find the entry point, which is at the lateral border of the lateral mass, intersecting with the pars. Okay, so that's your entry point. 5 millimeter, sorry, maybe less than millimeter caudal to that. And then you can, and then you also want to expose the foramina transversarium, the vertebral artery, to make sure you're above it. And then you aim medially along the pedicle. So you need to orient yourself by also exposing the joint and the pars itself, definitely the medial aspect of the pedicle. And these are really nice screws. This is a very well written paper to describe how to put a pedicle screw of C2. I think I'm not going to touch upon transarticular fixation. So that's what I have. Do you have any? We're almost done with this. So we explained different ways to managing patients with C2 type 2 odontoid fractures using C1, C2 fusions. So
that's a really good case, Nader, and I know Dr. Rao in the audience is interested. It seems like he has an interest in these cases. I think it's a really good idea to have a dedicated session. He brings up a good point. Dedicated session on EDS, hypermobility syndrome, connective tissue disease, connective tissue conditions, because their pathophysiology is a little different, and structurally sometimes. I mean, this was a case in which there was clearly structural anomalies there with a very low CXA and whatnot. But there are cases that are a little bit more subtle, and the decision making is very nuanced. And I had the fortune or misfortune of treating a lot of these patients in New York, and many of them got better. Some of them did not, and that's just the reality. But when patients do get better, it's life changing because nobody will touch them. You know, they go to a lot of people, nobody wants to do it. So I think if we all as a community learn from each other and to help these patients, I think we're doing a huge service to this patient population. That's a really good case and a good outcome. Well, yeah, we are, go ahead, Nader.
Yeah, I mean, I agree with you. I mean, the thing is, like, and we have a lot of CVJ cases to show and different pathologies, but I agree with you. This subpopulation is understudied. And, you know, the definition of what's stable, what's unstable, it's a spectrum. You know, true structural instability is at the one end of the spectrum that we see, we understand. There's subluxation, there's dislocation, there's evidence of that by craniometric measures. And at the other end of the spectrum, it's a stable spine, but whatever is in between is still open to further investigations and where we need to build up empiric evidence on what defines stability beyond those craniometric measures that we always use day in, day out.
Excellent. Well, thank you very much, Nader. Great cases and great discussion. Thank you to the great engagement both on the audience side as well as on our faculty and panels here. Dr. Gibbs, Rasuli, Dr. Galgano, thank you all very much. Hope you enjoyed the session today. One last session to end the academic year. Dr. Gibbs, would you like to announce the plan for next week?
We're very excited next week to have Dr. Galgano, who's still waiting for his case to start right now, still with us. He's going to show us some of his cases and some intraoperative videos. So that'll be fantastic. Can't wait to see what he has to show us. Same time next week.
All right, wonderful. So we'll look forward to hearing Dr. Galgano next week and see him showing off his incredible skills with the videos. So thanks everyone, and we will see everyone next week. Have a great evening, everyone.
Thank you.